Nikhil Parekh. Thank you so much, sir. Dr. Sanjeev K. Sharma. So you have to. Dr. C.B. Meena. Thank you so much, sir, for coming. Dr. Sanjeev K. Sidana. Thank you so much, sir. Thanks. Thank you so much, Dr. Ajit Bana. Now, quickly we will come forward to the session 3. And now, I would like to call upon chairpersons for the session 3, Dr. Jagat Narula, Chief of Cardiology, Mount Sinai at St. Luke's and Roosevelt Hospital, Director, Cardiovascular Imaging, Mount Sinai Heart Network, Philip J. and Harriet Leigh Goodhart, Professor of Medicine, New York. Then Dr. Anoop Jain, Professor and HOD Cardiology, SMS Medical College, Jaipur. Dr. Sanjeeb Roy, Senior Interventional Cardiologist, Director of Interventional Cardiology, Fortis Escorts Hospital, Jaipur. Dr. Jitendra Makkar, Director, Cardiology, Eterna Hospital, Jaipur. Dr. Atul Kasliwal, Associate Director, Interventional Cardiology, Eterna Hospital, Jaipur. I hope all of our chairpersons are on stage. And our one more chairperson, Dr. Dr. Dipendra Bhatnagar, please be on stage. A big round of applause for all our chairpersons for session 3. And now the session starts from you only, sir. Thank you so much.
So the first speaker for the current guidelines in antiplatelet therapy for acute coronary syndrome, choice and duration, it was supposed to be Dr. Usman Babar from Mount Sinai Health System, New York, but he could not be here because of the visa issues. His parents were born in Pakistan, so that was the problem, and he could not get the visa. And he's being replaced by none other than Dr. Sharma, and I don't think that I really need to introduce Dr. Sharma. Only one thing that I've always said and would like to say, the legend in our field. So, Dr. Sharma.
All right, good noon, and I'm sure this one will pick up some time. The slides which I'm talking now, just to give credit, because Usman Babar is on the agenda, so I told him still, I said, I need you to prepare the talk and give it to me. So he has given the talk to me, so I will be talking. Basically, the slides are from my associate Usman Babar, who misses to be here. But we'll go through those topics, which is the current guidelines in anti-platelet therapy for acute coronary syndrome, choice and duration. So basically, outline will be choice of the P2Y12 inhibitor, their pharmacokinetic and pharmacodynamic, depth in acute coronary syndrome with a clinical trial evidence, depth duration in ACS and evolving paradigm, particularly aspirin withdrawal. Now, antithrombotic mechanism, as we know, the whole thing starts by the interaction of the platelet with the endothelium and works through various receptors. The glycoprotein 2B3A inhibitor gets stimulated by, again, multiple factors, most important being the ADP receptor. And that's where the P2Y12 activity comes in. The inhibition of P2Y12, the whole focus of the antiplatelet therapy has been on this potent inhibitor of the ADP receptor stimulator. So clearly that after the adhesion, the release of factor propagation, thrombus forms, and goal is to inhibit this process at very early stage. We all know there are 3 drugs which are available in the oral form, the clopidogrel, prasugrel, and ticagrelor. All of them have their advantages and disadvantages. The clopidogrel is the indirect molecule which gets converted. Prasugrel is still a prodrug and is rapidly metabolized. And of course, the ticagrelor is a totally different compound. So once we talk about anytime switch from clopidogrel to prasugrel, will be still in the same class of category, the antiplatelet effect. Ticagrelor will be different. So you want to switch from prasugrel to ticagrelor, you have to think about giving a full loading dose. Once you are going from clopidogrel to prasugrel, the loading dose is not needed because this is in the same family. And the advantages and disadvantages are shown below. Clearly, the clopidogrel is the mostly widely tested drug, has been there for many years, and these 2 new drugs have come into our armamentarium, which we routinely use at present. So this is just basically going over their half-lives and other various pharmacodynamic effects. Most important being that prasugrel is very effective, lasts for more than 7 days. So anytime you have to inhibit or stop the drug 7 days before your non-cardiac surgery or cardiac surgery for that matter. And but at the same time, both the newer P2Y12 inhibitors are very rapid onset of action. Compared to 2 to 4 hours of the clopidogrel, it takes about 30 to 45 minutes. Clearly, all these agents have been compared against clopidogrel. This is the prasugrel, more platelet inhibition, as you can see, rapidly within a few minutes, starting with 30 minutes and so 75% inhibition compared to clopidogrel being 32%, and similar data for ticagrelor. Platelet inhibition, as you can see, very high compared to clopidogrel. So these agents, very effective, consistent, and that's why they have taken an active role in our therapeutic armamentarium in management of these patients of acute coronary syndrome or with intervention. So what are the evidence for, besides the pharmacodynamic effects, the various trials? The first trial was the CURE, which compared clopidogrel to the placebo and basically showed benefit. So that really came, placebo with the aspirin. So clopidogrel plus aspirin combination was superior, both in the acute coronary management and the PCI cure in the PCI group. So became a standard of therapy. Then there was a trial called Oasis Current 5, basically showed double dose. Clopidogrel was better than single dose, and so forth. But overall, it became standard using clopidogrel in, I would say, 15, 20 years ago. Then we still had a problem because event occurred. So what about taking newer agents? So prasugrel, again, very old trial, Triton-TIMI 38, which compared the prasugrel against clopidogrel and patients with a 60 milligram loading dose and 10 milligram daily maintenance compared with a 300 milligram loading dose and 75 maintenance. The only difference was the most of the time now we give 600 loading compared to 300 which was used in the trial, and basically showed that prasugrel was superior to clopidogrel in terms of the primary endpoints, death, MI, and stroke, but caused more bleeding and decreased the stent thrombosis in half. But issue was the bleeding. So therefore, the effective agent, but caused more trouble, more bleeding, although efficacious. And biggest question was the intracranial hemorrhage, which was not different, but fatal hemorrhage was significant, 0.4% versus 0.1% in the clopidogrel groups. Clearly, we were concerned, and we learned that it was more patients with a 75 years of age, underweight, 60 kilo, more age, 75, and patients who have prior stroke or TIA. So that became clear. It's contraindicated in those groups, and in younger, in the patients above 75 or weight less than 60, use a 5 milligram maintenance rather than 10. Then it was also compared prasugrel in two other conditions. One was active management, medical management of acute coronary syndrome, where it was compared against clopidogrel and prasugrel in not the PCI group. The TIMI, the earlier trial basically was in the PCI patient, but in the medical management, in the Triton was the PCI, in the medical management showed no difference. So clearly, once you have medical management of acute coronary syndrome, prasugrel is not your drug. Then question was, should you give it in the emergency room, which was the ACOS trial. All patients, acute coronary syndrome, get prasugrel before the angiography, or do it after the angiography, 60 milligram versus 30 and 30, and it turns out to be that it caused more bleeding. So you give it in the emergency room, not a good choice. Why? Caused more bleeding, and there was no difference in efficacy. So clearly learn that the prasugrel is a drug to be given on the table after the PCI, not before. Now we go to the second, which is the ticagrelor. The original Plato trial, again 18,000 patients, dose was 180 milligram loading with a 90 twice a day, and compared to clopidogrel 3 to 600, whether medical management or PCI, they gave 60 and 75 milligram daily. In this trial, actually, if many of the patients got the 90 milligram as acute coronary syndrome in the before the cath lab, and if they got the PCI, they got additional 90 milligrams. So clearly, the patients who are managed medically, 90 milligram first dose, followed by 90 twice a day. But if they got a PCI, either they got 180 directly or 90 after the angiogram additional dose. And aspirin dose was anywhere from 75 to 325, and turns out to be a smaller dose was better, 75 to 100, rather than going beyond. And that showed the data that more than 100 milligram of aspirin is not needed with the ticagrelor. And studies show again the benefit of the ticagrelor reducing the event, death, MI, and stroke, as shown here. And the management, the question was whether you take them to the cath lab or not cath lab. It turns out to be that both strategy, the ticagrelor are superior to clopidogrel, and it did cause bleeding, but not significant. So now we have the second agent. First agent, effective, prasugrel, but more bleeding. Now we have effective agent, but caused less bleeding, or not higher bleeding, and that led to a wide spread adoption of ticagrelor for management of acute coronary syndrome medical, as well as those who are undergoing PCI. Then question came, should you be giving this drug into the ambulance before they come to the hospital, particularly with a STEMI patient? So overall, it seems to be that by giving in the pre-hospital ticagrelor in STEMI patient, reduce the stent thrombosis significantly from 1.5% to 1% without any difference in bleeding. So you can give pre, no for prasugrel, pre, yes for ticagrelor based on the studies. And that led to the guidelines that patients who are ticagrelor is preferred to clopidogrel irrespective of the treatment strategy, whether they're going for PCI or going for conservative management of the acute coronary syndrome, and prasugrel is preferred over clopidogrel for patient undergoing PCI not at high bleeding risk. So those were the, basically from these three trials came. I have not used the intravenous IV cangrelor, but that is because not available here. So I think it will not be in the context. Another agent which was shown to be superior to just the clopidogrel, IV, you can call it IV Plavix, which is IV clopidogrel, very short acting, fast acting action, which in many cases we started using it now. So basically, summary, added to aspirin, clopidogrel superior to placebo, and then of course prasugrel superior to clopidogrel but cause more bleeding, and ticagrelor superior to clopidogrel for various ischemic endpoints and consistent across treatment approaches, and upstream administration is neutral, rather in some cases beneficial by decreasing the stent thrombosis, but bleeding definitely increases. Then question comes duration. So how long we should continue? Because acute coronary syndrome, we know that even if you have taken care acutely, the events continue to occur because multiple plaque rupture, multiple platelet activation continues, and of course then you put a stent. So even with the stent issue comes, you give it for 1 month, 6 months, or 1 year or longer. So multiple trials have done in this field, which have compared our standard 1 year treatment to 3 months, 6 months, 24 months, or even 48 months. So basically, issue comes that it's not in acute coronary syndrome. If we do a stent, we take care of the one area, one lesion. But what about the rest of the other vessels? Because in the past, used to say, the concept was acute coronary syndrome has a single culprit lesion. But since then, multiple studies of the imaging with the IVUS, OCT, angioscopy have shown when you have plaque rupture, you see only one which causing the event, but you take a careful look with the imaging, multiple, average 2.2 acute plaques are there in those patients. So you are taken care with a stent, so stent will decrease the event into that area, but what about the others? So there is a lot of hypothesis that these prolongation of antiplatelet therapy, particularly strong ones, may decrease the event, not necessarily because of the stent, because of the event occurring from the non-stent area in that vessel. And this actually has been the part of many of the study with the platelet inhibition, and one of them was the depth STEMI. It basically continue after 12 months in the trial, single, or you continue for 18 months of the double trial, and basically showed slight benefit, although it caused more bleeding. So key is that after 12 months, it's not a clear that you need to continue more, but 12 months was the minimum, of course, after the patients, these were randomized. So then there is one acute coronary syndrome trial of reducing the event, reducing the therapy from 12 months to 3 months. And it turns out to be, by reducing 3 months, you actually have a higher, the overall event rate was 8%, non-inferiority, but a small group, and the short DAP did have slightly higher event rate. So benefit was, if you combine both, bleeding as well as MACE were identical, but clearly you caused a little more MACE but less bleeding by using the short-term DAP therapy. Same thing is with the SMART, 6 months versus 12 months. All those have been into the guidelines, basically taking the balance of the ischemic risk versus bleeding risk, and those the guidelines are that patients at present with acute coronary syndrome should get DAPT for 1 year. In stable syndrome, 6 months, and acute coronary syndrome 1 year, and even longer based on the clinical scenario. Your patients who have very high risk, continue multiple events, you can continue more than 1 year. That's a different than stable syndrome. Stable syndrome, we are going down to 6 months, 3 months, or even 1 month with a newer stent. But acute coronary syndrome, just because not the stent-related event, many of them are a non-stent related event, you need to continue therapy for at least 1 year. So just to sum up, class 1 for 6 months DAPT, for DES in stable ischemic disease, 2B for more than 6 months based on the bleeding risk, but class 1 for patient with acute coronary syndrome, irrespective of the therapy, whether you got a CABG, medical therapy, lytic, PCI or so. So DAPT duration, shift is low, but 1 year for acute coronary syndrome. The last is, what is the issue about this bleeding? The bleeding and, of course, the ischemic endpoints are kind of go hand to hand, but at some point, the risk separates. That is, the ischemic endpoints or ischemic effect, the events occur early after the acute event, while the bleeding could continue throughout the patient's follow-up. So this basically has been the focus, that if you can just give a strong antiplatelet therapy acutely for short term, and then you avoid it for a long term, because then we are not worried about thrombosis or ischemic endpoint. We are more worried about the bleeding, so you can have a best balance. And that is where the de-escalation means the trials which were done, the Plato and the Triton, they gave the drug for entire 1 year, or in some cases longer, 15 months or so. So what if you give it for 2-3 months only, or 1 month, and then change, because after 1 month your risk decreases. So this has been the focus. And second is, all the trials included aspirin. So what if you take away the aspirin and just continue the single potent antiplatelet therapy? So that has been the focus of switching. And one of the trial was the TOPIC trial. That was the patient with acute coronary syndrome. All were on the P2Y12 inhibitor. And after 1 month, you switch. Basically, 1 month got the P2Y12. After 1 month, to switch to aspirin plus clopidogrel versus continue your newer P2Y12, and basically found a very important observation. That is, by switching, that you cause less bleeding, and there is no effect in ischemic endpoint. So very, very interesting. So now what happened is after 1 month, the benefit is there. So now the whole issue about the bleeding kind of disappears. And the ischemic endpoint did not change. So having said that, so seems to be that it makes sense, and this is a lot of trials going on at present. There is another one called Topic ACS. They have done the platelet aggregation and then switch. But what we started doing in our cath lab also, the patients who are little risk for bleeding, that it's reasonable to switch to a clopidogrel from the stronger agent after 1 to 3 months of acute coronary syndrome or for the PCI. Then second question comes to the aspirin. Aspirin, actually, you know, the many trials of the primary prevention have been negative published in last 1 month, but more important, secondary prevention is a routine, although there is no randomized trial. But now there are 2 trials looking into this effect. What if you give it aspirin only for 1 month? And that was the global leader trial, which was just presented last month, although it did not show any benefit, but at least gave the proof of concept that stopping aspirin at 1 month did not cause more thrombosis, as long as the background of the ticagrelor. Second is the trial which we were part of here, Twilight, that gave only for 3 months in a complex cases, but on the background of ticagrelor. And the trial actually, Roxana Maran, our ESCC enrolled 80 plus patients in this trial, 9,000 patient trial. Results will be available in next few years. Next year, AHA, just to say the concept that can you take away the aspirin and will decrease the bleeding without increasing the ischemic event. So at least to me, the global leaders, a lot of people say it's a negative trial, that 1 month of aspirin, but I said no, it was not a negative trial. It was a positive in the sense that door for our new thinking has opened. That by stopping aspirin, in 1 month, you did not increase the ischemic endpoint. So maybe all what we have been concentrating of the bleeding is not because of our stronger anti-platelet therapy. It was an aspirin combination. So if you take away the aspirin and the bleeding does not increase and still remain efficacious, endpoints will be ideally preferred. So this trial, as I mentioned, will be presented. And just to in the summarizing, the de-escalation of the aspirin, basically this is the field which is coming, but do not hesitate to take away the stronger P2Y12 inhibitor in this acute coronary syndrome patient after a short term 1 to 3 months of use, and if necessary, take away the aspirin. And that actually is the latest message in our intervention cardiology. Aspirin probably is the big culprit, and so much so, I think, for the primary prevention. And I'll make sure I'm sure we'll have some discussion. So that all the many groups, diabetics, patients with a high CAD risk scores, and so risk factors, aspirin turns out to be negative. Rather, it causes more GI bleed, and in some cases, even a little more cancer. So routine aspirin is going away, out of favor, both primary prevention as well as post-PCI. I cannot say for the secondary prevention at this time. Thank you.
Thank you, Dr. Sharma. Now it's my distinct pleasure to invite Dr. Samir Mehta. And as you all know, that Dr. Samir Mehta is the chairperson of the Lumen Foundation and Lumen Global, STEMI director at the ITMS, Miami, Florida. He is an astute interventionist himself and has probably gone across the world and has established the STEMI networks. So very unique experience and very unique projects that he has done. And he speaks on the role of telemedicine and artificial intelligence in STEMI interventions. Dr. Mehta.
Dr. Narula, thank you for your most kind introduction. Let's try to save lives of people in Rajasthan from heart attacks. Now, in doing this, I am going to first of all tackle the relevance of telemedicine. How exactly can it play a role? And I'll lean on some work which we have been doing in South America and come back to tell you how it relates to saving lives in Jaipur as well as in Rajasthan, plus hopefully in India. Dr. Sanjeev Sharma is going to be talking more details about RAHAT, but I will lean on it and I'll tell you how exactly telemedicine and artificial intelligence is going to affect it. As difficult and as strange as artificial intelligence seems to you, I think it is high time somebody in Jaipur came here and talked about it and set the footing. I plan to do that right now. And let's see if a combination of telemedicine and artificial intelligence can contribute to saving lives from heart attack in Rajasthan. So as Dr. Narula kindly mentioned, this is the work of Lumen Foundation. It was in 29 countries. In the last 3 months, we have expanded work in Chile and in Argentina in South America, and it remains a proud privilege in life to help so many people save life from heart attacks. This was our landmark publication on the role of telemedicine. I think this is possibly the world's most effective technique to decrease the disparities between developed countries and developing countries. Let's show you how we have done that in parts of the world. So this is the power of telemedicine today. This is the continent of South America. How many people are now covered with the umbrella of heart attack management with the work we have done? 100 million people. And this is the data I have just submitted to the American College of Cardiology. And out of this 100 million people involving in 5 countries, we have had 734,000 telemedicine encountered, and this yielded 8,000 patients with an acute MI. This is possible also in Rajasthan. This is how the program has been created. The purpose of it is to increase access and to do it cost effectively. These are the various components of the Latin telemedicine system. This is the country of Brazil, almost 3 times the size of India. And watch here how we have connected. This is how the methodology has been used to include 51 million people in the country of Brazil, a giant country. How we have used small primary care centers, small clinics, created a telemedicine pathway. We know exactly how to work on the ambulance system, what kind of therapy they can get, and the management of an entire country of Brazil. This is more data recently submitted. Now this is back to Brazil. The same methodology for Colombia, Mexico, 103 centers, all being managed out of the country in Colombia, and this is the recently added Argentina. One of the things which we understand is once you start applying telemedicine, you are basically providing specific care and you avoid unnecessary transfers. Of course, it is important to save lives. With this data, we have demonstrated here that since the time telemedicine has been used in the Latin program, we have saved almost $100 million. So not only are you going to be saving lives, you will save money too. We took this data and started projecting that at the rate we are going, 735,000 patients today. In 2026, this is going to be 5 million patients, 71,000 patients treated with heart attacks, and $844 million saved, all data recently submitted. We don't even believe today that a door-to-balloon time is the best initiative. We actually use a new term known as time to telemedicine diagnosis, and that is clearly related to mortality. We have also incorporated data from the Latin program. Now this is taking into what we call big data. I'm going to move into it very quickly in artificial intelligence. And once we start reviewing it, we realize that women, we know traditionally have all sorts of barriers in getting treatment from heart attacks. We thought maybe telemedicine is going to eliminate some of the barriers. Unfortunately, our data demonstrates that is not the case, that these barriers still remain. Why did I decide to put this topic here? Because I can guarantee you, give it a few months, a few years, RAHAT program in Rajasthan is going to come out with this data. This is big data. Put it in a computer, put in a machine learning program, you will be amazed the information you're able to get. We have also used partnerships with cardiac societies. This is the Interventional Society of Mexico. We joined it with Latin, and now you realize the coverage of a country, almost 30 million people covered with the common methodology. Believe me, it can be done in Rajasthan. What is the future of Latin? Where do I think it is going? I think there are going to be special areas how the program is going to get better. I think the telemedicine component is going to have incorporation of artificial intelligence, machine learning, far greater GPS tracking, which we are also using in RAHAT. There is going to be further cloud computing, Internet of Things, and I can bet you we are right on target that we can cover almost 650 million people in South America using the trajectory we've already had. So this is the role of telemedicine. Can it be done? I can guarantee you, and Dr. Sharma will convince you how the RAHAT program is addressing that. Here is the RAHAT program, the detail, absolutely the most advanced telemedicine-based system right here in Jaipur. Let's try to figure out how to optimize it, how to utilize it better. I'm going to shift gears now and talk to you about my most recent area of research. This has been over the last almost 18 months. This is a group of 24 dedicated people looking into mainly artificial intelligence. Now, this used to be a difficult term. People used to struggle with it, no more. Here is a new Apple 4 watch, which now is able to detect atrial fibrillation right away. And just watch, I'm going to show you, maybe this is possible also with STEMI. This is no longer so new. It is mainstream, it is headlines. This is what is happening in the United States. In fact, almost as strongly as United States, it is China which is probably taking the lead today in artificial intelligence. But you are going to see it used in areas of medicine that will surprise you. I can bet you what Dr. Rajiv Gupta presented today, you take this data and apply techniques of artificial intelligence, you will uncover areas which you cannot believe. What exactly is artificial intelligence? So here is the first definition coming from the year 1956 that you are basically talking about thinking machines. A machine which is going to think like a human being, and this definition is almost similar with the English Oxford Dictionary in the Encyclopedia Britannica, but the best definition actually comes from Amazon.com. How exactly they define it, it is a field of computer science dedicated to solving cognitive problems commonly associated with human intelligence such as learning, problem solving, and pattern recognition. This is also the same technologies which are being used for autonomous driving. I can also tell you that amongst all the companies, IT companies in the world today, it is easily Amazon.com, which they have a special part of it, Amazon Web Services, which we have started partnering with, which is possibly in the lead today. 7 terms of artificial intelligence you need to master today. These are what exactly is big data, what do machine learning mean and imply, what exactly is deep learning, what is cognitive computing, how do you have the computers do a supervised learning, unsupervised learning, and a reinforced learning. These are relatively simple terms. If we could master and become cardiologists and interventional cardiologists, have no fear. This is not going to go away, and the sooner we learn these terms, the sooner we recognize the power of artificial intelligence, I think we'll become better physicians. This is a recent application. It was a JACC editorial, how these 7 components are going to be applied in medicine. And I'm happy to share with you the previous slide, which specifically tells you how each of these terms, big data, machine learning, deep learning, will affect medicine. Let's try to see how it affects saving lives from heart attacks. Before that, there is always this apprehensions and fears which come in your mind. How could it be so straightforward? Maybe there is a downside. So let's take a look. These are the advantages. I can tell you artificial intelligence is going to be the best solution we know of saving lives from medical errors. Several 100,000 patients in the United States, only in the United States, die each year from this. Watch what machine learning and artificial intelligence can do. It is going to replace the humans in a lot of administrative tasks. It is also going to be a powerful tool for fraud detection. It takes away the emotional factor out of decisions. That is why artificial intelligence is going to be used in the financial world in picking up stocks and making these financial decisions. Of course, the advantage is you don't need sleep, you don't need breaks, all you need is power. The computer is going to find you solutions. However, there are disadvantages. There is a high cost of equipment, high cost of maintenance. There are all sorts of ethical and moral values. When you're trying to teach a car to drive, if something goes wrong, does it hit 2 people or a child? These are issues. Believe me, we'll solve them. Where it is more important in medicine is that it may lead to loss of the human warmth and consideration, and of course the potential of causing millions and millions of people losing jobs. And of course, we also realize that in areas of arts and other creative fields, it possibly will have zero application. This is a recent definition by the CEO of IBM, some people call this artificial intelligence, but the reality is that this technology will enhance all of us. Instead of artificial intelligence, think of it as intelligence enhancement. The sooner we adapt it, the better it will be for us. So where does it lead with acute myocardial infarction? When you're dealing with STEMI, I do not know of another procedure in medicine which is so time dependent, where there are so many aspects of the process which even today in the most sophisticated countries are inefficient. Let's see if we can improve them. This is how the timeline of the electrocardiogram started. In 1986, it was first invented. Then we started having it recorded. We started printing it. I think in 2018, it is going to be the application of artificial intelligence which is going to take it to the next area. This is not new work. There are all these papers, all this research, a lot of this cited here is from Japan, using artificial intelligence to improve the STEMI process. However, with my background of using telemedicine, I think I'm in the lead in applying artificial intelligence to STEMI. How exactly does it do it? Now, in India, we are struggling at the moment with ambulance systems. This will improve. It dramatically improves the ambulance systems. It helps you bypass the emergency room, and it is going to provide you real-time data. It helps the patient in personalized care, and it helps the hospital in increasing efficiencies. I'll show you exactly how it is able to do it. So this is the first part, what we started researching. In the years I have been working with the Latin system, we have access to the biggest data on the planet. And when you started applying this data to machine learning, some of the results coming out are amazing. As an example, An emergency room physician has a 77% accuracy in diagnosing STEMI. Most general physicians, about 78%. A machine today is able to do it much better, almost 98%. We have demonstrated it and submitted it to the American College of Cardiology. Application of telemedicine with fast and accurate diagnosis of ST elevation. It is possible out of the 735,000 patients which are coming to us that the machine will immediately rule out, this is a normal patient, don't even bother. So now the physician is looking at definitely the one with defined pathology. That is going to be the next step, and I think it is not too far away. Why do you need a 12-lead EKG? Maybe you don't. Maybe the machine can do something better, and we have explored, looked, and found the reason for it, that you can apply a single lead to diagnose STEMI. This is the advantage that once you have a single lead, you eliminate the human error. You are able to now put it on a wearable sensor like the Apple Watch I showed you. It provides you continuous monitoring, and you don't have to worry where it is recorded. Dramatically better than what a 12-lead EKG can do. So with single lead, we explored all of it. You have to just do a supervised learning with artificial intelligence, and this is the information we found after subjecting the machine to millions of patients of big data, and this is a part of the ACC submission we have just done last week, application of artificial intelligence to detect ST elevation myocardial infarction with the single lead EKG. An event which can dramatically change how acute myocardial infarction is managed, is treated for millions of patients. So these are the two specific abstracts. I'm going to read it exactly here, how they will involve. Recent submissions, fast and accurate diagnosis of ST elevation MI using innovative machine learning algorithms. What would this do? This is going to reduce door-to-balloon times, improve outcomes. We have figured out that it can remove 22 minutes out of a door-to-balloon time, which calculates to a 3.6% absolute reduction in mortality. I can also demonstrate to you that it is possible today to have a wearable STEMI device which can lead to early detection of STEMI with the high level of sensitivity and specificity. I can also make a personal projection that I think my next area is going to be combining artificial intelligence into various aspects of telemedicine to offer global templates for acute MI care. So in conclusion, this is what I think is going to happen. The RAHAT program, which Dr. Sharma is going to talk about right now, I think is easily the most innovative, cost-effective methodology to save lives in Rajasthan. You will understand it, and I think we should also utilize the time today to figure out how to use it more appropriately. And I also strongly believe that artificial intelligence will dramatically improve the way how we manage patients with heart attacks. Thank you so much.
Thank you, Samirji. And the last talk of this session is current status of STEMI care in Rajasthan, insights from RAHAT. And this is from Dr. Sanjeev Sharma, who is the Director of Interventional Cardiology at Eternal Hospital. Sanjeev Sharma.
So as they set up the laptop, it was an excellent overview of use of machine learning and artificial intelligence in the diagnosis and the treatment of STEMI. And it's all about dedication from Dr. Mehta in improving the care of STEMI day by day, month by month, year by year. He has something new to add on for the STEMI care whenever he comes. So now we're moving to the STEMI. You can take in the pen drive and then you input it. Okay. Yeah, I think this is okay. It's a very new concept, Dr. Mehta. Just like Apple Watch for the detection of atrial fibrillation. In times to come, if the MI can be diagnosed by the single lead EKG on the watch, and it's being directly transmitted to the family physician, and who can immediately report it to, and then patient can be referred to the nearby cath lab center, then definitely the STEMI care will go to the new level. This is not the presentation. This is not the RAHAT program. Presentation is different. Let's go to the desktop. Here's the PPT file. STEMI care. Yeah, let's go to that. Let's see how to do it. Slideshow. Now all set. Now the topic for the next is current status of STEMI care in the Rajasthan and insights from the RAHAT. So the important question is, why should we discuss this topic? The current status of STEMI care in Rajasthan, or you can say the STEMI care in India. So why do we need to discuss about it? Because it's not the people who can perform the primary angioplasty, but the important part is a system and processes on which Dr. Mehta is working upon. This timely detection, the patient should be diagnosed in time. Whenever he has symptoms, he rush to the nearby physician and get an EKG done within 5 to 10 minutes time. And then it should be transmitted to one of the cath lab centers. And then once it has been diagnosed, it should be transferred with the minimum possible time to the cath lab centers, and the immediately primary PCI is being done. Or if the distance for traveling is long, more than 90 minutes or 2 hours, then one can go for the thrombolysis in the nearby medical center, or while transferring in the ambulance, and then subsequently go for the PCI. This, the system and processes, it needs extra efforts to make, and this is, we need to understand how we can apply this. Now there is a significant mortality difference in the developing and developed world. When you talk about the United States of America, mortality has come down significantly by improving the system and process. STEMI, diagnosed in time, they're being referred in time, pre-hospital thrombolysis, taken to the cath lab, and primary PCI 24/7, or the pharmacoinvasive, and get the best possible results. And we are still in the evolving phase. In the developing country, its still mortality is 8 to 10%, which is quite high, at least 3 times of what we see in the developed world. Now, this is the Global Disease Burden Study 2016. It clearly shows, you can see the top one line is coming down, is the USA. And all the developing countries, which includes India, Pakistan, and Nepal, is going up. So it's all about the understanding the system and processes of diagnosing and treating the acute MI in time and acute coronary syndrome as a whole. So we need to have an early diagnosis, early transfer, and early reperfusion. And we all are aware, in 2018, primary PCI remains the gold standard. But how many people can have access of primary PCI? Most of the people are very far off in rural area. The concept of time is muscle, is age-old concept, and each and every one of is aware. India has a significant population in the rural area. So rural versus urban divide is quite significant. And Dr. Rajiv had shown clearly in the PURE study and all other many epidemiology study which is being conducted by Dr. Gupta as a part of India Heart Watch, clearly says that there is a significant rural versus urban divide and poor socioeconomic versus high socioeconomic divide. So 90% of rural people don't have a timely access to cath lab. And they are likely to have a delayed diagnosis and delayed thrombolysis that leads to the further complication in terms of the pump failure, patient presents the heart failure, or the mechanical complication like a mitral regurgitation and ventricular septal defect. So all are a result of a delayed diagnosis and delayed treatment. The data from CREATE registry, this is the first registry which prospectively studied acute coronary syndrome in all across India. And it was published in Lancet in 2008. So this registry evaluated treatment and outcome of ACS in India over 30 days' time. So followed up for 30 days, all the patients across India being admitted at different sites. So the 89 centers from 50 cities in India, and the whole spectrum was studied. ST elevation MI, non-ST elevation MI, unstable angina. And recorded treatment pattern and range of clinical outcomes, including 30-day mortality. So the treatment pattern, how a patient was being treated, and the ultimate outcome, hard endpoints like 30-day mortality was recorded. Enrolled more than 20,000 patients, which is quite a big number. Out of the 20,000, had a high, 60% of the patient had a ST elevation MI. This is unlike developed world, where patient presents in time. There, ST elevation MI and unstable angina are more common than ST elevation MI. Because here in India, we get the patient a little late. The patient try to avoid the symptoms. And unless the patient has a worsening angina, then only the patient go to the physician and get the EKG done. So we see patient a little later. So high incidence of ST elevation MI as compared to the developed world where we see more common is the ST elevation MI or the unstable angina. And the patients are literally younger. The mean age was 56 years. This is, you can see in all European American, it's a 60, 65 years age, a time of presentation, average mean age. Here it's a 56 years. The patients are younger, the patient presents a little late. And the median time from symptoms to hospital access was 360 minutes, like 6 hours. 6 hours of delay in reaching the hospital or primary medical care facility. And the primary PCI was performed in just 8% of the patients. If we talk about United States, Dr. Mehta will be having the data, how many patients have access to the primary PCI, more than 60%? So, and the thrombolysis was done in 58%, and out of these, majority were from STK, streptokinase, not with the fibrin specific, like a single bolus injection of tenecteplase or retinoplase. It was, majority had been given streptokinase injection, and 30-day outcome was, death was 8.6%, which is quite high. Reinfarction 2.3%, stroke 0.7%. And the important endpoint was mortality was higher in the poor patient as compared to the rich patients. The 8.8% versus 5.5%. So there is a poor versus rich divide. The evidence-based treatment, poor people don't get, that's the big difference. So to summarize, the CREATE registry, high rate of ST elevation MI than Western world, the poor social class less likely to get evidence-based treatment, greater 30-day mortality, and the reduction and the insight is reduction in delays in access to the hospital and provision of affordable treatment could reduce the morbidity and mortality. So we need to have a system or kind of a program in our country by the government so that the affordable treatment should be provided to most of the patients, and for that people are working on the insurance part. The waste registry is still going on, and all across the India, there are 5 centers from our Rajasthan, and 3 centers are from Jaipur. One is SMS Hospital, one is Fortis, one is EHCC Hospital, and 2 more is Dr. Jain Hospital in Sikar, and 1 more in Jaisalmer. They don't have a cath lab. So the 5 centers, we have preliminary data taken from Dr. Rajagupta. This is going on, multi-center prospective registry across India, 5 centers from Rajasthan. From Rajasthan, we have got 1,824 patients, 1,800 patients we have enrolled till now. Around 50% are ST elevation MI. The close to 95% patients have undergone PCI in corporate hospital. Like out of 3 hospitals, 2 are corporate, more than 95% patients are going for the PCI. And 65% in the government hospital. And in non-PCI center, there's only one center which is for a center where don't have a PCI facility, and that has 55% patient going for the lysis. And the overall mortality is close to or less than 5% if you take it into account. And in tertiary care center, it's close to 2%. That is quite significant reduction. This is a transition from 2008 to 2018. Over these 10 years, definitely the system has improved. The patients are understanding better. They are reaching the primary care center. But this data is only from the 5 centers. But it's not the uniform data. We are not having a data from the rural, all the centers don't have access, or all across. These are 3 centers from Jaipur and 1 from Sikar and 1 from Jaisalmer. So it's very difficult to generalize. But definitely we are having a better system and processes. We are having a timely diagnosis and timely treatment, especially from the corporate hospital where 24/7 cath lab works. And definitely all the centers in Jaipur are doing an excellent job in providing primary PCI. And city-wise, we have a great care. But what if the patient is 120 kilometers away or 200 kilometers away? So how to minimize that delay in the diagnosis and treatment? People are from far off. So just to give the brief glimpse of how the patients are coming to our hospitals. The case 1 is a 45-year-old smoker male. He's quite young, 45 years. He presents to primary healthcare center with 12 hours duration of chest pain. It's a little delayed presentation. And primary healthcare center, they did ECG, diagnosed anti-wall MI, but they didn't thrombolize. Well, you came late, let's manage it conservatively by anti-platelet, statins, and LMWH, and referred on day 3 to our hospital. Already 3 days have already elapsed. And then when patient presented to our hospital, he was in class 3 heart failure. Ejection fraction was 25%. The whole LAD territory was thinned out and akinetic. We cannot take straight away in such a decompensated phase. We stabilized with decongestive therapy, anti-platelet statin LMWH. After stabilization, he was taken for diagnostic angiogram. It will be 100% occlusion of the osteoproximal. So late presentation, after 3 days, 100% LAD, 25% ejection fraction, heart failure. So what the guideline says, to look for the viability. And viability also a gap of 7 to 10 days, because the MRI and the PET scan, they have a better assessment of viability after a week. That MRI revealed non-viable LAD territory. And the patient is now optimal medical follow-up, but still remains in class 2 to 3 heart failure. Still he is symptomatic. Just by walking few steps, he is having dyspnea. Now, looking back, he's a 45 years old. Had an MI, just because of delayed presentation and delayed referral, the patient has ejection fraction 25%, and now it's for lifelong he will be in heart failure, or ultimately he might be a candidate for cardiac transplantation. Now, in contrast to that case, the second case is 55 years old diabetic hypertensive male who presents to the ER within 1 hour of chest pain to our hospital ER. He is a corporate employee, very close to our hospital. He came within 60 minutes. ECG was done, STEMI. Immediately cath lab was kept standby, shifted to the cath lab. EF was 45 to 50% baseline. Straight to cath lab. PCI was done within 30 minutes of presentation to the ER. And his LU was well preserved on discharge, 50%, and he resumes work within a week and he's having a normal quality of life, walks 4 to 5 kilometers a day. So this is a sharp contrast. The patient who's coming from rural area and one is from urban area, very close and having a best possible care. So these two cases clearly shows how timely diagnosis and early reperfusion makes a difference in the overall outcome in ST elevation MI. It's very important to diagnose early and treat early. And all the system and processes, what Dr. Mehta is working on now, coming to machine learning and artificial intelligence, they are going to that level. But still we are struggling in a basic setup so that we can diagnose early and shift the patient early. Because interventional cardiologists have a number of interventional cardiologists are there. Even in the smaller towns, we are having an interventional cardiologist these days. But the thing is, patient are not being diagnosed, delayed ECG, delayed referral from the physician side, and not being having the best possible care. This emphasizes the need for the improvement in system and processes by telemedicine-based integrated program for the early diagnosis and treatment. And this is what we got from Dr. Mehta. He's all the time, last more 20 years, he has been working 24/7. This Rajasthan Heart Attack Treatment Program is a brainchild of Dr. Mehta, and all the push from Dr. Samin Sharma, so that we have implemented this RAHAT program at our hospital. But it's not the planning part, it's a long exercise. First, they planned, they did a lot of work, and they planned with a soft link, and everything was in place, and then we inaugurated this program. But after the implementation, we are having a long way to go. We are improving on each and every step and system. In STEMI care, we started with the 4 or 5 spokes. Atul Hospital was a hub center, which has got 24/7, the telemedicine system, and we had put in 5 machines at different places, from where we can have a 24/7 EKG. And as soon as the EKG comes, alarm is raised, interventional cardiologist nearby, he sees the ECG, diagnose, and then I will show you how system works. The patient with a chest pain reaches to one of the spoke. As soon as the ECG is done, it goes to the cloud and come to our command center, that is a hub. And the hub operator sees the ECG, calls cardiologist, diagnosed. As soon as the ST elevation MI diagnosis is being made, the cath lab is alerted, the ambulance driver is alerted, and ambulance is being dispatched. So we are not losing time. Meanwhile, ambulance is going to the spoke center, the cath lab is already activated, and the second ECG is being taken, and that is being transmitted just to confirm the diagnosis. And you see, that ambulance movement is being tracked through GPS. That ambulance moving to a spoke, everything is being monitored in real time. And as soon as the ambulance reaches, it picks up the patient, and before reaching hospital, registration, all the formalities are done before coming to the hospital. And the green corridor is created, and the patient comes rushed straight to the hospital, and the emergency department is bypassed and rushed straight to the cath lab. And the primary PCI is being done in a minimum possible time. So whole exercise is to minimize the delay to avoid delay and a transfer of the patient and providing the primary PCI in minimum possible time. That's the crux, how we can reduce the mortality in our city of Rajasthan. So RAHAT, we are still learning, even after the 1.5 to 2 years of, we're still learning with the logistics and other issues. We are working on educating the people, educating clinicians, everyone, so that we can have a timely ECG transmission. And if it's being diagnosed, still patient doesn't reach hospital because of many other issues after diagnosis. So the brief about the data, we are getting 300 to 400 ECG in a month from different spokes. Out of them, the diagnostic lead is less than 5%. And of those, 1 to 2% usually reach for the PCI. And some of them, they go here and there. This is because the people or general public is not educated. They don't understand this is acute MI. They look for the second or third opinion when the precious time is already lost. They wait for the 2 hours, 3 hours, whether it is a definite heart attack or not. So these are the issues which we encounter in routine practice in our city and country. So what are the points which we need to work upon? We have to educate. It's a lack of education in the general public. We need to educate physician community also. So whenever there is an acute escalation MI, it's an emergency. You should, either you do a thrombolysis if the transfer time is more, if the transfer time is less than 120 minutes, send the patient to nearby cath lab center and get the primary PCR done. That will go in a long way in reducing the mortality. Second thing is that the physician, definitely at times what they do is, they thrombolize, they keep the patient for 2-3 days, and when the patient decompensates, goes into acute LVF, having a recurrent post-MI angina, or having a ventricular arrhythmia, they refer the patient to the nearby cath lab center. That's already the myocardium is lost. So benefit is not much. So the crux is diagnose, treat in time. Third is the insurance, because we have seen the rural versus urban and the poor socioeconomic versus high socioeconomic divide in the create registry. So the people are poor, but still they can afford. Still, if they get a government insurance or the public-private sector partnership through, if they get insured, definitely the large section of the society will be having a primary PCI care. And that's very important. And even the people, what we see in a routine practice, even if the people can afford, the average middle class family, they don't take insurance, medical insurance. The 50 to 70% of the patient who can afford it, still they are not being insured. And when they have acute catastrophe, acute emergency like escalation MI, they usually refrain from going for the PCI. They don't have money. So we need to educate the people about the importance of getting a medical insurance. If they can get it done, it's very good. Otherwise, government policy, just like Bahamasha or some other insurance which can provide or cover the large part of the population. So even the poor patient can get the quality care and primary PCI in time. And that goes a long way in reducing the mortality. So we need to educate general public about if they have symptoms, they should rush to the nearby medical center for time diagnosis, as well as physician community to diagnose and treat in time, either a LICE or do a PCI. And government or private insurance cover for all the STEMI intervention, we should continue to discuss with the government authorities for the insurance cover for all, especially poor patient. And we too can achieve 2 to 3% escalation of my mortality target in times to come in all across. So we have got a RAHAT helpline. Those patients who don't have access to the nearby spoke center, they can call on this number and they can transmit their ECG. If it's a escalation of our ambulance can rush and can transfer the patient and provide the primary PCI in a cost-effective way. So it requires the involvement of all the physician community and all the interventional cardiology community for getting together and achieve the target of reducing mortality to 2 to 3%. That's our target. Together we can. Thank you.
Thank you, Sanjeev, for a very, very interesting presentation. Now, there is a small change in the program. Rather than having the panel discussion, we will invite Dr. Jeffrey Olin for his talk before we go for lunch, because he has to leave and his plane is at 4 o'clock. So Dr. Jeffrey Olin, who is the chief of the vascular medicine in the Mount Sinai Health System, an excellent clinician, is one of the foremost investigators in the field of vascular medicine in states. So peripheral vascular disease, current insights into diagnosis and treatment. Jeffrey Olin.
From various areas from Rajasthan, the RAHAT program which Sanjeev just showed, interested, please approach us. We want to extend the program which is now in 5 centers and can very well service 20, 30 centers, and so very much interested. The whole goal is to improve the STEMI care of our Rajasthan people from Rajasthan.
Thank you. I'm going to do my best to stay on time so everyone can have lunch. I'm going to talk about peripheral artery disease and 2 aspects of it, the effect it has on cardiovascular outcomes and the effect it has on limbs. Here's an example of a CT angiogram, and you can see here, you could see there, sorry, the aorta is occluded, there's a very severe right renal artery stenosis. It's images like this that allow the interventionalist to plan the intervention and be able to revascularize the aorta when it's totally occluded like this today. These patients don't go to surgery anymore. They're treated entirely from an endovascular approach. So, peripheral artery disease is the presence of a stenosis of the aorta in the lower extremities. This is the thigh. And you can see here the superficial femoral artery is occluded. The profunda femoral artery is the major source of collaterals around an occluded superficial femoral artery. And this is why patients can occlude this artery and not develop critical limb ischemia, because they have such good collaterals. The 2016, the ACC-AHA guidelines on the management of peripheral artery disease was updated in 2016, and you can find them in the Journal of the American College of Cardiology in circulation, a number of societal journals that participated in this. I want to tell you something, though, about peripheral artery disease. We were all taught in medical school that these patients have claudication. In fact, only 10% have claudication, classic claudication. 40% have what's called atypical leg pain, and 50% are asymptomatic. They have no symptoms at all, yet their cardiovascular morbidity and mortality is extremely high. It's these patients that are never identified until they have their first myocardial infarction, stroke, or death. So if you're expecting your patient with peripheral artery disease to experience classic claudication, it's not going to happen. This looks at the ankle brachial index in close to 50,000 subjects, over 480,000 person years of follow-up. This is measuring the blood pressure in the ankle and comparing it to the arm using a handheld Doppler device. And normal values are between 1 and 1.4. And as the values go down, the cardiovascular event rate goes up. So the lower the ankle brachial index, the higher the rate of myocardial infarction and cardiovascular death is. So this is a very, very important predictor. In the Barry 2 trial, in those patients who had low ankle brachial index and coronary disease, they had twice the mortality of patients who had coronary disease alone. And if you want to look at it in comparing it to the Framingham risk score, if we're taking 0.9 as defining peripheral artery disease, we know these patients between 0.9 and 1 still have a slightly increased cardiovascular event rate. But those patients who are between 0.9 and 0.71, they have a 5-year risk of 10%. If you have an ankle brachial index of less than 0.7, your 5-year risk is 19%. A Framingham high risk is 20% at 10 years. So every single patient with peripheral artery disease is a high risk by Framingham score, but they're a high risk at 5 years. They have the same event rate that a Framingham high risk has at 10 years. So on the left-hand part of this slide are the goals as far as decreasing the risk of myocardial infarction, stroke, and cardiovascular death. The right-hand side of this are what we want to do to improve symptoms, quality of life, and prevent amputation. Many of them are the same. Tobacco use, a structured walking program, control blood pressure, high-dose statin for both groups. This not only affects cardiovascular event rates, but it affects limb outcomes as well. Anti-platelet therapy, and this morning I added this, anticoagulant therapy, because as I'll show you, the COMPASS trial now showed a dramatic improvement in both cardiovascular event rate and limb salvage rate. And I'll go over those details in a minute. So how do we do? We don't do very well. These are data from NHANES, and it showed that among the 6% or 7 million people in the United States with peripheral artery disease, only 30% were on statins. Now, only 25% were on ACE inhibitors, and only 36% were on aspirin. We do not do very well. Physicians don't equate peripheral artery disease with coronary disease. And among those who had no clinical cardiovascular disease, the use of multiple preventive therapies was associated with a 65% reduction in lowering all-cause mortality. So if you use optimal medical therapy, it's effective. These data from Aaron Armstrong demonstrate on the left major adverse cardiovascular events, on the right major adverse limb events such as amputation, critical limb ischemia. On those patients on less than 4 guideline-directed therapies, shown in red, you can see the cardiovascular event rate and the limb rate is markedly higher than those patients who are on 4 or more guideline-directed therapies. So you can have a major impact on cardiovascular events as well as limb events. Now, you all know well about antiplatelet therapy for coronary disease. And I'm not going to belabor the point, other than I will show you one trial on ticagrelor, comparing it to clopidogrel, because ticagrelor was beneficial in people with coronary disease. And I will show you one trial using the thrombin receptor antagonist Vorapaxar, and see if you can put these into perspective of how these patients should be managed. You're all familiar with Capri. Capri was published 20 years ago. What Capri showed was that those patients, this was a trial comparing aspirin to clopidogrel, and what this shows is the 6,500 patients who were entered into this trial because of peripheral artery disease, they had a 24% relative risk reduction in MI, stroke, and death. So this led to guideline-directed therapy as clopidogrel as single therapy as the treatment of choice if you have peripheral artery disease and no known coronary disease. Now so we thought, because the coronary trials were so positive with ticagrelor, we planned this trial of ticagrelor versus clopidogrel in patients with symptomatic peripheral artery disease. And basically, we used a dose of 90 milligrams twice a day versus 75 milligrams. Every patient was checked to make sure they were a responder to clopidogrel. So anyone who was not a responder was not entered into this trial. And 13,800 patients were randomized. The primary efficacy endpoint was cardiovascular death, MI, and ischemic stroke. We thought for sure this was going to be a positive trial. Negative trial. No benefit. Ticagrelor was not superior to clopidogrel. It was as effective as clopidogrel, but not superior to it. What about Vorapaxar? Remember the TRAP secondary prevention trial, TIMI 50 trial, randomized 26,000 patients. And I'm not going to go over that data, but pre-specified a group of patients, 3,500 patients, were pre-specified entered with peripheral artery disease. And it was cut off at that point. No more patients were allowed to be entered into that. And the results of Vorapaxar showed, and we have multiple publications on this, showed that Vorapaxar substantially decreased the rate of acute limb ischemia, hospitalization for acute limb ischemia, and substantially and significantly decreased the rate of urgent vascular hospitalization. Now, as you know, there were some bleeding problems with Vorapaxar. What the role of this drug is going to be in peripheral artery disease is unclear. It's probably not going to play a major role just based on these data. This, however, is going to make a major role. This is the COMPASS trial. COMPASS was published in New England Journal. I'm going to show you these data. And then the coronary group and the peripheral artery group were subsequently published in The Lancet. Among patients with stable atherosclerotic vascular disease, those assigned to rivaroxaban 2.5 milligrams twice a day, plus aspirin 100 milligrams a day, had better cardiovascular outcomes, more bleeding, but not more serious bleeding, than those assigned to aspirin alone. Rivaroxaban alone did not result in a better outcome than aspirin alone. And these are what this study, 27% of the people entered into this study had peripheral artery disease. So about 2,500 of the 9,100 patients in each group. And what you saw overall in the trial is that there were highly significant reductions, 25% relative risk reduction in cardiovascular death, stroke, or myocardial infarction. Importantly, there was a highly statistically significant decrease in death from any cause on those patients who were on river plus low-dose river plus aspirin compared to river alone or aspirin alone. And here's the Kaplan-Meier curve of rivaroxaban 2.5 twice a day and aspirin 100 a day. Major bleeding occurred more frequently in the rivaroxaban group, but if you look at fatal bleeding or serious bleeding, there was no difference between the two. So yeah, there was a slightly increased bleeding complication rate, but not serious bleeding and not intracranial bleeding. And when you look at the net clinical outcome showed a 20% relative risk reduction, highly statistically significant. Every single group did better on the rivaroxaban aspirin group. The PAD subgroup paper was published in The Lancet, and this showed that in patients with peripheral artery disease, the group that was entered with PAD alone, they had the same benefit. And the PAD group is a higher risk group. And you can see here that the rate of cardiovascular death, stroke, and myocardial infarction was reduced by about 28%, highly statistically significant. The group with cardiovascular death, MI, ischemic stroke, and acute limb ischemia was reduced by about 30%, highly statistically significant. And here are the Kaplan-Meier curves regarding that. And if you look here on A is major cardiovascular events, and every group with peripheral artery disease benefited from this. B is major adverse limb events. Every group with PAD benefited from this. C is major amputation, and D is bleeding. So you can see that bleeding was increased, but amputation was decreased, major limb events were decreased. It's going to be very interesting to see the results of the Voyager PAD trial. The Voyager PAD trial is a trial to see what happens in patients who have undergone either surgical or endovascular intervention. And here's the design of the trial. Technically successful lower extremity revascularization. They're stratified by surgical, endovascular with clopidogrel, endovascular without clopidogrel. There'll be very few of these because everybody uses clopidogrel. Randomized to placebo plus aspirin or rivaroxaban 2.5 twice a day plus aspirin. And the primary endpoints you can see here. So this data will be out in about 12 to 18 months. I want to just quickly finish with indications for revascularization. If you have iliac disease, you would know that by hip, thigh, or buttock claudication. If you examine the patient, you would feel reduced or absent femoral pulses. These patients should be stented. The results with stenting are so good. If you have infrainguinal disease, then they should be given a trial of 4 to 6 months of an exercise program, cilostazol, and probably ACE inhibitors. If they fail that trial, you should do additional imaging and then consider either stent placement or drug-coated balloon placement. I'll show you a study on that in a minute. Don't forget that the people who end up with amputations are usually diabetics who have peripheral neuropathy, so it's very, very important to make sure their feet are inspected at every visit and that they're fit with proper orthotics to prevent amputation. A quick case, a 62-year-old with half-block claudication. He's a short walker, heavy smoker, very low ankle brachial indices. You can see he has significant iliac disease here. He also had significant superficial femoral artery disease. This is a CT angiogram. He had good 3-vessel runoff. So we thought we would stent the iliacs, see how he did, because he smoked about 4 packs a day, so he wasn't going to be able to walk that long anyway before he got short of breath. Stented the iliacs. He was very happy with the way he walked, and we didn't need to do anything with his superficial femoral artery. Here's an example of a short SFA lesion. And multiple studies have now shown that stent implantation is superior to balloon angioplasty. I haven't put the study in here, but drug-coated stents, such as the Zilver PTX stent, is much better than bare metal stents, significantly better for long SFA lesions. And there are multiple trials now on drug-coated balloons, and drug-coated balloons specifically for short lesions or infrapopliteal lesions are very, very good, where you don't have to put a stent in, but you can use a drug-coated balloon and get very satisfactory results. This is a great paper if you want to read a summary paper on critical limb ischemia. No one really knows what's better, surgery or endovascular therapy. This trial, published a long time ago, was before many of the medicines we have now. These 2 trials are ongoing. The best CLI trial is an NIH-sponsored trial. They're aiming to recruit 2,100 patients. Recruitment has been slow. They've got about 1,600 patients to date. And this is comparing surgical bypass versus endovascular therapy for patients with critical limb ischemia. So the recommendations are that endovascular procedures are an effective revascularization option for patients with lifestyle-limiting claudication or CLI. It's reasonable for patients with claudication and hemodynamically significant FEMPOP disease. And then these 2 trials are going to tell us which is better. So I'm going to end here and let everybody go to lunch. Thank you.
So thank you, Dr. Olen. Just stay up. Dr. Penny also, please, and all the speakers, Dr. Sanjeev Sharma, so that we can have a picture here. And 20 minutes for our lunch. Thank you.
क्या करूँ अभी फेलिसिटेशन करना है या नहीं करना है should I announce for the felicitation because everybody is done for the I have to announce